Welcome everyone. In this video, we are going to continue our discussion on the DNA viruses. This is a part of the discussion of DNA viruses, and this is the third part in which we will go through the DNA viruses important points for step 1, 2, and 3. So in this video, we'll conclude the discussion on DNA viruses, and once you have mastered the DNA viruses, you will be able to confidently answer the questions on your step examination, like with greater than 90% scores. And if you like this video, please like, share, and subscribe for more. And let's begin our discussion from HHV4, right? Okay, suppose you have a patient and he has basically developed, he has like some sort of symptoms of infectious mononucleosis, which is basically a teenager or a young adult who has fever greater than 38 degrees Celsius, has lymphadenopathy, has tonsillar exudates, and has a lack of cough. So there's no lack of cough, right? And looks like the infection is bacterial, right? But it's possible that once you do the blood test, the patient has atypical lymphocytes, then the diagnosis is basically infectious mononucleosis, and the virus that is causing is an Epstein-Barr virus, which is HHV4 virus. And then they can ask you, like, this can be connected to the step 1 and the step 3 stuff, right? What is the structure of this particular virus? So remember from a discussion of the herpes viruses, they are like simple like linear viruses. So it's double-stranded linear, and along with double-stranded linear, it's an enveloped virus. And then of course, like, it has an icosahedral shaped nucleocapsid, right? And then after they say that this patient has this infectious mononucleosis, they can ask you, what are the other diseases caused by this like particular virus or infectious agent? Or they can ask you, like, what is this patient at increased risk of, right? So he can develop nasopharyngeal carcinoma. So not only does this virus cause infections, it causes carcinomas as well. And it is implicated in both Hodgkin's and non-Hodgkin's, particularly Burkitt lymphoma. And the patient can also develop oral hairy leukoplakia. So many things related to the head and neck and the chest. That would be nasopharyngeal carcinoma, oral hairy leukoplakia, along with Hodgkin's and non-Hodgkin's, which is Burkitt lymphoma, right? So, and then they can also ask you this, give you the same Vinay of this young adult or the teenager, and they can ask you for the pathophysiology. So the pathophysiology would be that the virus invades which type of cells? B cells. Then it stimulates the immune system to produce which type of cells? CD8 plus T cells. And these B and then the CD8 plus T cells are then going to basically attack the virus infected B cells. So the virus is going to attack the B cells, but the CD8 cells are going to attack the B cells. Therefore, that is the particular reason that in this particular disease, the immune system is basically making lot of CD8 plus T cells. So what would you expect on the blood smear would be lots of atypical lymphocytosis. Atypical lymphocytes, it can also be caused a reactive lymphocytosis due to the T cells affecting the viral infected B cells. Okay. And next off, this is also like important that you know that this, you can like misdiagnose this patient as having strep pharyngitis. So in the CCS cases, not only are you going to order the heterophile antibody, but you're also going to do a rapid strep test just to rule out that this patient does not have strep pharyngitis, because the treatment is very different. In case of strep pharyngitis, you must get amoxicillin or penicillin. But if you accidentally, to your CCS cases patient or your real patient, give amoxicillin or penicillin in an EBV patient, then this patient can actually develop a particular sort of rash. So amoxicillin or penicillin is basically avoided in this sort of patient, right? And this rash is not due to actually like a beta-lactam allergy, but this is a sort of like in case of EBV, if you give this drug, then the patient develops this sort of rash, right? And if a patient on adolescent, he gets a rash, then of course the next step is that you're going to do heterophile antibody monospot test, right? That would be your next best step in diagnosis, because the EBV mono is likely. So if they say that the patient self-medicated or some other doctor gave him amoxicillin or penicillin and now he has this rash, immediately your mind should go to EBV mono, right? Next off, like, of course, like, this is the like the reason that they can ask you that why the patient like tests positive for the heterophile antibody test, right? How this is used for the diagnosis. So how it is used for the diagnosis is that the antibodies that are produced against EBV, they basically cross react with the horse and the sheep RBCs, right? Therefore, like we can use the horse and the sheep RBCs to make this diagnosis. That is why it is known as the hetero a hetero which is for different, and the phile which is for like antigens. We use heterophile antigens from the horse and the sheep RBCs because the antibodies basically cross with them, right? And then following the primary infection, they can ask you about the prognosis of this patient, that what is this patient likely to develop in this future. So he can have recurrent episodes of extreme fatigue as well, right? And of course, I told you that what is another disease that is caused by this particular infectious agent. That would be squamous cell carcinoma, that is nasopharyngeal carcinoma. And suppose they give you another patient who has white lesions of the tongue that cannot be scraped off, right? Remember, this is very important, that this is not regular leukoplakia which like caused by tobacco, which basically can be scraped off, right? So if it cannot be scraped off, then the diagnosis is oral leukoplakia, right, caused by our EBV virus, which is HHV4. But if they say that there is white lesions of the tongue which can be scraped off and it is a tobacco smoker, then this is a regular leukoplakia, and which is a precursor of squamous cell carcinoma. And this oral hairy leukoplakia is basically non-cancerous and there is no dysplasia, right? So the HHV leukoplakia, although it causes nasopharyngeal carcinoma, but the leukoplakia that it causes is non-cancerous. But the tobacco regular leukoplakia, which can be scraped off, is basically a precursor of squamous cell carcinoma. Then of course I told you that because EBV has invaded the B cells, in the future this patient is at increased risk of Hodgkin's and non-Hodgkin's lymphoma along with the Burkitt lymphoma, right? Next off, we have another HHV virus, which is HHV5. So let's see how this organism is commonly transmitted. It's commonly transmitted by blood transfusions and organ transplants. Suppose they give you a patient who has renal transplant, and after it he develops pneumonia, and then they give you this buzzy image of this owl eye appearance. Then the diagnosis would be cytomegalovirus causing pneumonia, and which can alternatively of course be called as HHV5. So how do we remember? Like up until now, let's do a quick review of the HHVs. The number 1 and 2 are of course the herpes simplex viruses. The number 3 was the VZV, common varicella zoster virus, which can basically of course like cause the shingles along with the chickenpox, right? And it can also cause pneumonia. Then next we have the 4, which was the EBV, and next off we have the 5, which is CMV. So up until now we have reached up to 5, and then we will do 6, 7, 8 as well. Okay, so this is specifically a virus of the immunocompromised patients. And what is a buzzy thing that you can basically found in the Vinay? Presence of intranuclear inclusions or intranuclear inclusion bodies, right? Or owl's eye is something that you can be present in CMV. And of course we found out that we discussed this earlier, that we have an immunocompromised or an AIDS or a chemotherapy patient who is CD4 count is basically between 50 and 100, and the patient has linear or confluent ulcers and has difficulty swallowing. Then this linear confluent ulcers is CMV esophagitis, whereas if he has punched out ulcers, then this is HSV esophagitis. And similarly, in the same immunocompromised patient, if we have linear confluent ulcers present on colonoscopy and the patient has GI symptoms, then he has CMV colitis. Whereas if there is blurry vision in an HIV patient, then this is CMV retinitis until proven otherwise. So these are the 3 integrations for HIV patient. Then difficulty swallowing is can be CMV esophagitis if he has linear ulcers. If he has GI symptoms and bloody stool, then with linear confluent ulcers in the GIT on colonoscopy, then it can be colonitis. Whereas of course if he has having immunocompromised with vision problems, can be CMV retinitis. Then there's another disease that can also be caused by CMV, that the presentation can be very similar to mono, right? As we discussed earlier, that there's a teenage young adult, fever greater than 38, lymphadenopathy, tonsillar exudates, lack of cough, right? But they also mentioned that the heterophile antibody test is now negative, monospot test is negative. So it means that the EBV is now ruled out. So now you are going to think, oh, does this patient have HIV? Is he developing CMV mono, right? So how are you going to diagnose CMV mono? For this, you are going to have a positive Coombs test. So now after you have ordered, of course, the EBV monospot or the heterophile antibodies, once it is negative, then you can also develop a Coombs test. If the Coombs test is positive, it means that it's possible that the patient has CMV, because the CMV infection is known to cause autoimmune hemolytic anemia, in which IgM antibodies are present against the RBC. So the Coombs test is basically going to be positive. So that will confirm that it's possible that the patient patient is developing CMV mono, right? So if the patient with mono has low hemoglobin and high LDH, then the presence of low hemoglobin and high LDH is telling you that there is some sort of autoimmune hemolytic anemia. So in the same way, for the mono patient, but the patient has low hemoglobin and high LDH, automatically you should think of autoimmune hemolytic anemia and CMV mono, right? So this is basically indicating that some sort of hemolysis is taking place. Then they can ask you, okay, this is the patient, of course heterophile antibodies were negative, the hemoglobin was low, LDH was high, and Combs test was positive, right? How are you going to treat this patient? The treatment is ganciclovir, not valcyclovir, right? Because previously we were giving, for EBV we were giving valcyclovir, but for CMV but the EBV mono is basically not treated. Valcyclovir was for AHSV 1 and 2, right? So for CMV, we're going to treat with ganciclovir, and they can also ask you the mechanism of resistance, which is same for acyclovir, DNA polymerase inhibitor, causes chain termination, and then the CMV resistance can be caused by alternate viral thymidine kinase, right? So this is very important that you know these causes, that you know these mechanisms as well, especially for step 1 and step 3. So if we had a kidney transplant 6 months ago and now the patient has deteriorating renal function with intranuclear inclusions, then the treatment, they can simply tell you that what's going to be the treatment. The treatment will be ganciclovir therapy for this patient who is developing CMV. Now what is the key? So how do you know that this kidney patient and developing deteriorating renal function, but this is specifically CMV and not the earlier? Remember we studied that the BK virus can also cause deteriorating renal function. These intranuclear inclusions are basically differentiated from BK because BK basically has a specific immunostain that can be done on the biopsy, and of course like it can also have some viral serology that can be positive, but the internuclear inclusions are very specific for CMV. Next off, we are going to study HHV 6, 7 and 8. So let's make them these three together, right? But basically we can divide the HHV viruses, like how I like to divide them is that for the ease of like memorization, I like to divide them into first 3, middle 2, and then the remaining 3, right? So the middle 2 I remember with etc., right? So it's EBV along with CMV, right? And the middle ones I like to remember along with like HV, right? What is HV? It is HSV 1 and 2, and then VZV, and then we have 6, 7, 8, which we will study right now. So okay, let's go through the 6, 7 and 8, what they do and how we are going to diagnose each of them. So suppose you have a kid who has spiking fever followed by a rash. So very high grade fever, goes up, goes down, goes up, goes down in the form of spikes, and then he develops rash, right? So they can simply ask you, so what's the treatment? Or they can simply ask you for the diagnosis, or they can simply ask you for the infectious agent. So the treatment will be self-limiting, no treatment necessary, but just like if you get the CCS case of the spiking fever, you're going to rule out all the other infections, and then this would be a diagnosis of inclusion, right? And then the diagnosis would be roseola infantum 6 disease, also known as exanthum subbiticum, and the infectious agent would be HHV 6, human herpes virus 6. That's why it's known as 6 disease, exanthum subbitum, or roseola of the infantum, roseola of the infant, right? And the kid can have a maculopapular rash. It's so worrisome that the kid has such high fever, but once the rash is formed, you should know that the kid has basically cleared the infection. And this is very similar to the slapped cheek of 5th disease caused by parvo. Once he developed this slapped cheek, it means that the infection is cleared. Similarly, if the kid after the spiking fever develops the rash, it means that it is basically cleared, right? So HHV6 does not have a specific name, but remember the disease roseola infantum 6 disease or exanthum subbiticum. Next off, if we are shown this picture in which there is a large pink ellipse, right, on the back or the trunk that spreads upward in a Christmas tree distribution. So this is the first ellipse or oval macular rash that he develops, and then he develops further rash moving away from that particular rash in a Christmas tree distribution. Then the diagnosis will be pityriasis rosaceae, and the particular virus implicated in it would be HHV7. Of course, like you should remember again a quick review of the viral characteristics. It's a GNA virus. It's very simple. So it is double-stranded linear, and it's an enveloped virus, and it's icosahedral nucleocapsid in shape, right? And then it can be a teenager, most common in the 20s, may or may not be itchy. And if they ask you about the treatment, no treatment necessary, just like for roseola infantum or 6 disease or exanthum subbiticum, HHV6, right? Okay. Next off, we have HHV8, which is also known as Kaposi sarcoma associated virus. So suppose that you have violaceous tumor lesions of vascular or lymphatic origin. So you do a biopsy of the lesion and they say that there are like lots of vascular proliferation within the lesions, and the patient is basically immunocompromised, had AIDS or chemotherapy. So keep this at the back of your mind that it can be Kaposi sarcoma caused by Kaposi sarcoma associated herpes HHV8. And of course, if they ask you like how will you diagnose it, you can just do a HHV8 immunostain on that particular biopsy, or you can do of course like the blood test for HHV8. And if you show you the image, and then like if they ask you for the treatment is basically an anti-neoplastic. So you are going to, of course, like it's cancer, so you are going to treat it with some like chemotherapy, right? And then this Kaposi sarcoma like lesions, the one important differential diagnosis that you have to keep at the back of your mind for these patients who have these vascular lesions, vascular raised violaceous lesions, is bacillary angiomatosis that is caused by Bartonella Hansley. So Bartonella Hansley is the same organism that can cause cat-rat disease, but for the immunocompromised, it can cause these violaceous vascular raised lesions also. The diagnosis for that is bacillary angiomatosis. And of course, like how can you differentiate it? You can differentiate the definitive diagnosis is by doing a biopsy, or of course if you found the infectious agent in the blood, right? And so you have to know that these violaceous lesions that are present in an AIDS patient, what is the organism causing it, right? So you'll also notice that HHV8 as well as Hep C for lichen planus like isn't listed. So the answer, if they don't list the HHV8 or they don't list Hep C lichen planus, then of course the answer would be a bacteria which is Bartonella Hansley. So they will give you one of the two. Either they will give you Bartonella Hansley or they will give you HHV8, right? So because they clinically they present the same, right? Suppose you have a patient who has a history of kidney transplant and now he has developed wheezing in both lung fields, and this is the biopsy specimen. So remember the biopsy specimens showing these two owl eye like appearance, right? So this owl eye appearance in this patient in the biopsy specimen tells you that this is basically a CMV infection and this is CMV pneumonia in this kidney transplant patient, okay? And of course, like some more things about the HHV8, it can have multinucleated T lymphocytes that refers to Warthin Findelke cells, which can be harvested from the tonsils of the patient in the prodromal stage. And the intranuclear inclusions, also known as Cowdery bodies, also associated with the herpes viridae family. And you can also have small or medium-sized lymphocytes with cerebriform nuclei. And this disease is known as mycosis fungoides or Sézary syndrome, which are basically cutaneous T-cell lymphomas and leukemias. And these conditions are basically associated with human T-cell lymphotropic virus. And just like a quick review, let's quickly review our DNA viruses and conclude this video. So in order to divide the DNA viruses, we are first going to divide them by nucleocapsid, two types of nucleocapsid. First, the simple one in a tubular, secondly the complex one, which is icosahedral. In the simple one, we have the simplest virus, which is the pox virus, whose name is the simplest. With the simplest features, it is double-stranded linear, a simple feature, and enveloped and inner tubular nucleocapsid. Next off, in the icosahedral, divide them into enveloped and non-enveloped. Enveloped are the more common sort of viruses, right? Which is the Hep B, very common, herpes, very common, right? And for the Hep B, I told you, we are going to remember it with this, that it is an infection that goes on and on circularly inside the community, right? So Hep B is going to be the double-stranded circular enveloped icosahedral nucleocapsid. Whereas herpes viridae is the linear infection, goes from one person to another in a line, right? And in that, of course, we are going to divide it further, HSV1 and 2, VZV. This is the first three. The second two, which are remembered by etc. First through three, which are remembered by HV, HSV1 and 2, VZV. Then we have EBV and CMV. And then, of course, HHV6, causing roseola infantum, exanthum subiticum, 6 disease, or HHV7 and then HHV8. HHV7, which was basically causing what? HHV7 was causing our, pityriasis rosacea, and HHV8, the Kaposi sarcoma associated virus, and then of course like ABV, CFV, and now you know the herpes viridae, but they are linear, double-stranded linear, enveloped, and as the icosahedral nucleocapsid. Next off, we just have the non-enveloped. So non-enveloped are the rare or the weird viruses. In them as well, double-stranded linear and the double-stranded circular, always the one that is linear is the simpler virus, right? So adeno is the simpler, and the linear goes on and on in a circle in the immunocompromised HPV, GC, and BK virus. And then we have the single-stranded linear, which I told you that this is the exception of the DNA viruses, the smallest virus, which is single-stranded, and that is the parvovirus B19. And so that would be non-enveloped as well as a icosahedral nucleocapsid. So that concludes our discussion on DNA viruses. I hope that you find this video beneficial and that it will help you through all of your steps. If you like this video, please like, share, and subscribe and follow for more. And I'll see you in the next video.